The final section of this chapter looks at options for managing patellofemoral instability when you get it after calipered kinematically aligned TKA. And when will this occur? Generally when you flex the component, generally when you use a domed button. Option 1 is observe the patient with patellofemoral instability, and of our 13 we were able to do this in 4 patients. This is an example of patient with an onset of patellofemoral instability 5 months after the calipered kinematic alignment. So this instability was bothersome, but it really wasn't disabling to her, and she elected not to have another operation. In this particular example, only the right knee had patellofemoral instability, even though both kinematically aligned TKAs had similar flexion of the component, of the femoral component and alignment, and similar size implants. So let's look at this case, which illustrates a few points. So this is the right leg. Patient has patellofemoral instability. This is the flexion, 10 degrees. And we looked at the IE malrotation of the tibial component on the femoral component, which was negligible. And if we look at the other side of this patient's knee, and you can see that we restored pretty much the same limb alignment, joint line alignment of the distal femur proximal tibial, which is the goal of kinematic alignment, and the left knee had no patellofemoral instability. And once again, you can see we still had too much flexion at the time this was done. We'd now like this at just 1 or 2 degrees. And once again, no real malrotation. So why is there this instability on the right leg but not on the left? And so we wondered here, could a prosthetic trochlea that's redesigned explicitly for kinematic alignment that provides more lateral coverage of the femur promote the tracking if it had been available? So if we look at these 2 knees, you can see that if we could increase the lateral extension, which was more uncovered in the right knee than the left, it might have lowered the risk of instability. So there may be a measure of improvement with a kinematic designed femoral component. Option 2 is reoperation with a arthroscopic lateral release. This was effective actually in 2 patients. This is a case example that shows the alignment of one of these patients that was treated with an arthroscopic lateral release. And you can see on this left limb that she had a history of patellofemoral instability, and there was about 7 degrees of flexion. But the knee was not an excessive valgus, and it was just sort of unexplained. We performed the lateral release 7 months after the primary KTKA, which was performed at that time, which was in 2007, with patient-specific instrumentation, or the so-called Otis knee. 8 years later, she self-reported an acceptable clinical set of outcome scores. Her Oxford knee score was 44, and the forgotten joint score was 63. Now, with our current technique, the forgotten joint score median is usually in the high 70s to low 80s. The third option is reoperation with an open lateral release and medial reefing. We performed this in 6 patients, and let me show you an example of how this can occur early on when we had a poorly fitting patient-specific femoral guide. So this is a cadaver, but it sort of shows how sometimes these guides can be moved into different positions, and if it locks too flexed, you'll end up flexing the femoral component. And this happened in a few patients in 2007, and hence was a cause for some of the patella issues, which were few in the study by Dawson and by Young, their 2 randomized trials. In this patient, a huge amount of flexion, 24 degrees. Native limb alignment was restored, not too valgus, and she did well with a proximal realignment. However, the difficulty of performing that operation is while you're in the operating room, if you passively move the knee, you can't detect the instability. So once you do the repair, you can't determine whether or not you've done the correction. So this is a pre-op exam. And then same patient interop. And you cannot make the patella jump when you passively move the knee. If we externally rotate the foot. And so a lateral release and a medial reefing did not eliminate the patellofemoral instability in 4 of the 6 patients we treated. These patients had a much lower median Oxford knee score than we like at 33 and was lower than the 44 median score of those of the controls. So in hindsight, I think the better initial treatment might have been a revision of the femoral component and setting the flexion at 0 degrees instead of the excessive flex position. However, the implant brand where this occurred most commonly did not have a revision component for the femoral side, which would necessitate an entire revision of the knee. So to summarize this chapter, the typical onset of patellofemoral instability is atraumatic, and it occurs at an average of about 5 months, which is a period of time that's required for the soft tissue to overgrow the dome patella button. Flexion of the femoral component and a dome patella implant increases the risk of patellofemoral instability. Use of a verification check that there's a 5 to 10 millimeter bone bridge between the posterior aspect of the positioning hole and the anterior aspect of the notch, and an anatomic patella implant reduces the risk to less than 0.1%. A prosthetic trochlea designed explicitly for kinematic alignment so that it covers the lateral femur would be an improvement. And observation, arthroscopic lateral release, and revision of the femoral component are now our preferred corrective options when this occurs. Thank you.